diabetes. She's 41 weeks. And she presents to labor and delivery. She's 3 centimeters on admission. On admission, she is 100% effaced. She's at a -2 station. Okay, just so we're all on the same page, does everybody know what we're talking about? And don't be hesitant to say, I don't know. Do you understand what station is? Okay.
Okay, my only question about station, is it just completely subjective, like between like -1 and -2? There's no like actual measurement, like
Technically there is, but it really is subjective because it's done in a subjective way.
Yeah.
You're not taking a radiograph from the side, but it's where the sacral spines are, okay, and the spinous processes, excuse me, and that is where 0 station is. So a centimeter above it is -1, a centimeter below it is +1. That came about in the years before we became sane and sophisticated, and they used to measure this through the rectum. So they wouldn't put their fingers in the vagina, they'd put them in the rectum, find the spines, and then they defined where the head was in relationship to that. It's a whole lot harder to find the spines in a pregnant woman unless you're really going to push posteriorly, because they're deep in the pelvis. So it's a relationship to the spinous processes.
You mean the ischial-spinous?
Spinous process. What did I say?
You keep saying spinous process, but I think you mean the ischial spine, right? The pelvic inlet?
The ischial spine,
Yeah.
right. Okay, to me those are the spinous process, but you're talking about vertebral. To me that comes
Yeah,
down.
see, we're DOs, so we're always like, spinous process.
No, I'm talking about in the pelvis.
Gotcha.
Okay, so that's how you measure station from. Centimeters is how open the cervix is. How about effacement? Anybody understand effacement?
Isn't that the thickness?
Yeah, but think about this. Stupidest thing we do in obstetrics. Okay? What is the length of a normal cervix? Anybody?
That's a good question.
Anybody take a guess? This is we all pitch in, and it's absolutely perfectly fine to be wrong. Take a guess.
3 to 4 centimeters.
3 to 4 centimeters. Anybody else want to?
Are you talking about like thickness or
The length.
the length?
She's right.
From the internal os to the external os.
I'd say the same thing, but 3
3 to 4? Okay. 2 to 6 centimeters. Okay? So, if a normal cervix is 2 to 6 centimeters, how effaced is a 3 centimeter cervix?
Depends.
Correct. The point I'm getting to is that made sense when one person followed a patient from the beginning of pregnancy to the end of pregnancy. Now you could say she started at 6 centimeters, she's 3 centimeters, so she's 50% effaced. But when she comes into labor and delivery, and I hear people say she's 70% effaced, she's 30% effaced, I keep looking at them going, compared to what? Really today in obstetrics, in labor and delivery is what your documentation is. It's either thick, medium, or it's thin. It's the only 2 things you need to know. It's very thick, it's kind of, I can get into it, but it's just like that, or it's paper thin. That's all you really want to know. So that someone can talk to the next person and say, has it changed? That's what it's all about. You could do centimeters, but it's difficult sometimes to really assess where that internal os is. So that measurement's a little vague too. Does that make sense to everybody? Okay. So you got Mrs. Smith. She's a nice lady. She's laboring 3 centimeters. And then about 10 hours later, she's 8 centimeters. Made some progress. Still at a -2 station. Doesn't change 100%, can't get any more effaced than that, right? Okay, so then a couple hours later, she becomes complete and she starts to push. She pushes for 2.5 hours and you start seeing the head come out to the introitus, which we call crowning, correct? You see that? Okay. So she pushes and the head comes out and you see it. And then you lose the chin. Sucks right back up against the perineum. Anybody know what that sign's called? Turtle sign. because it's a turtle sticking its head out of its shell and pulling it back in again. What is the reference? What does it mean? It means here's the shoulder, here's a neck, and there's a head. Okay? The head has expulsive forces pushing it out, but the shoulders is stuck behind bone. So it pushes the head out, the neck extends, but then the neck goes back to normal, pulling the head back into the perineum. So the first thing we're going to talk about is a entity where the turtle sign occurs, and it's called a shoulder dystocia. Now, this is what I want you to do now. There's a pelvis, okay? And in essence, well, that's probably a bad way to draw that for you. I'm going to draw it the way I normally do. I was trying to be more creative for you. Here is the symphysis, and here is the sacral hollow. Okay? Baby's sitting like this. Here is one shoulder. Here's the head, the neck, and here's the other shoulder. Okay? So, what I want you to do is say, forget this is a baby now. Forget it completely. It's geometry. How do I get this to go through this space? That's what it's all about. Now, pelvises tend to be, when you look down in them, they tend to be more, that's even a bad joke because it's not quite that. That's more platypus. It's more rounder but longer this way than that way. Okay, so when you look at it from down. So, here's what I want you to do. We're going to call this a shoulder dystocia. The shoulder is stuck behind the symphysis. The other shoulder's laying in the sacral hollow. Okay, how do you suggest that we get that size through that device, that opening? What's the first thing we want to do in this emergency? Is it an emergency? Absolutely. You've got a baby, his head sticking out and you can't get the rest of it out. Let me show you what's happening in the room. Mom's yelling, "Get my baby out!" Grandma's yelling, "It's turning blue!" The nurse is yelling, "Do something." The doctor's yelling, "Holy shit!" Okay, so everybody's going crazy, but you as the doctor and you as the nurse have got to gain control and decide what we could do and start thinking rationally. So any emergency, what's the first thing you do?
Activate the system.
Okay, so you're going to call for help. Always the first thing you do. Get help in the room. The more people you have at that point, the more things you can ask to be done. Number two, what are you going to do after you call for help? You're the practitioner, and let's say you're the nurse in the room and nobody else is there. The doctor was out having coffee. Remember one time Dr. Dolkart was stuck on the toilet. Baby delayed. We all laugh about that to this day. But, so what are you going to do next?
Try to facilitate release of that.
How are you going to do it? Forget it's a baby right now.
Reduce.
Physical space.
You could either try to try to increase the space.
Okay, so the first thing you're thinking is, how do I increase the space? Okay, how do we increase the space?
Maneuvering the
How?
maneuver. I read about something called a McRoberts maneuver.
Okay, so the first thing you're going to try to do is a McRoberts maneuver. What is a McRoberts maneuver? The thing I tell people is introduce their feet, okay, or their knees to her ears. Okay? When I teach this to the paramedics, they always say that's how the baby got in there, so it's helpful to get it out that way. But that's another story altogether. But what does that do? It does two things. It brings this backwards, the symphysis, so it rotates it backwards. And you know more about this. It increases the hollow. The sacral and lumbar curve goes bigger. So baby settles down this way, and this angle becomes a little bit bigger than the straight up and down would be. So that's the first thing you do. Good. Now you understand why you do it. You're increasing the space. Is there another way to increase the space? It's way down here.
Any cut at all? Or,
Cut what?
Like a episiotomy or something.
Cut what?
Episiotomy.
Is it soft tissue that's holding that baby in?
No.
Does episiotomy not help you?
Okay.
Are you thinking like C-section? Cutting the oh, that's a further down.
The symphysis.
That's it. In Africa, they do a symphysotomy. They literally take looks like a carpet knife. Reach up behind the symphysis, move the urethra to the side, because it's running right down the middle, right? Move it to the side, bring it out, and slit it.
Oh.
The bone falls apart, increasing the space, baby falls out. We don't do that in this country because women walk around with corsets for the rest of their life and pain in their symphysis, but their baby gets out. So they do this. It's a very much a third world country. They do it in Africa all the time. We're not in Africa. So are there any other ways we can increase the space? Not really, because it's a bony space. So you can either tilt it, increase that curve, but there's nothing else that you're going to increase it other than to separate the bones, which you did down here with the symphysotomy. If you can't increase it, what are you going to try to do next?
You know, sometimes they use suprapubic pressure,
What does that do?
push the shoulder around the bone.
Okay, except, okay, this is bone with vertebrae and bone. How much can you squish it?
So you crack a
You
baby.
could break the
Yeah,
clavicle.
brachial
Breaking the
process.
clavicle is another thing we're going to do down here.
Yeah.
But if you can do it, your hands are better than mine. Okay, fracture the clavicle. Why? Because if you fracture the clavicle, the shoulder's going to fall in. Why is it so hard to do? Why am I telling you that?
Needs
How
more
big
help.
is your clavicle? Your clavicle is probably about that long. Okay, I might be able to get in there, take two pieces of it and snap it. Baby's clavicle's that long. Okay, do you think you can get in there and break that? I've never known anybody that can do it. It's in all the literature. Baby hits the symphysis sometimes coming out, smack right in the middle of that clavicle, you hear it go snap. But for you to get in there with your fingers and manipulate that tiny little bone and twist it in two different directions to make it happen, doesn't happen. You're on the right course, okay? But this is what I want you to think about. When you push suprapubically, which is the right thing to do, you don't want to push this way. You want to push slightly this way. So that instead of pushing straight down, you're trying to rotate it around to gain some access to this angle. Because right now the baby's in this position. So it increases the space.
So you push more like forward? Kind of?
You're pushing down but off to the side enough that you're shoving it down and over. So you're trying to rotate it and down at the same time. So your vector, instead of being what you were thinking, the vector was straight, that's even curved, I'm sorry. The vector you wanted was this way, and I'm just saying make it slightly more this way. Okay? Now, which way do you want to push? Do you want to push it to the left, or do you want to push it to the right?
Depend on which side the baby was stuck on, wouldn't it?
Well, baby's stuck right up and down.
Oh,
Okay, so which way do you want to push it?
The shortest distance to rotate the baby.
Well, it's the same distance either way,
If it's stuck in.
if it's stuck in the middle.
Generally, you want to do anteriorly.
Okay,
So
I think you're saying the right thing, but I don't know what anterior means. What I look at this is if I take you, I'm going to use you, okay, because you're sitting in the front. It is harder to take these shoulders and bend them backwards as it is to bend them in this way. So, whichever way the head is facing is the way you want to push down and in, because you're going to roll that shoulder in, because it's hard to roll it out. Make sense? Okay. So the next thing you're going to do is suprapubic pressure. Good answer. Okay, so that doesn't work though. So just so you know, we're about 45 seconds out now. Baby's turning a little bluer. Grandma's on the ground now crying. Okay, the whole team. You called you did. You hit that button that says call everybody. So every resident in the house is now at the doorway watching what you're doing. So you don't feel nervous or anything, okay? All right. So what do you want to do next?
reverse neck Roberts.
I'm sorry?
Reverse neck Roberts. Maybe.
How's that going to help you?
If it doesn't go one way, we can try to see if it would.
McRoberts, you mean bring the knees down is all
Sorry.
McRoberts is.
Okay, then I meant like try the root. I forget the name of that process where you try to like change the shoulder.
Like the corkscrew thing?
Yeah.
You want to do, it's called a Woods corkscrew
Yes,
maneuver.
yes,
Now,
so we
a
were-
Woods corkscrew maneuver is an internal rotation, the same exact thing you were trying to do with suprapubic pressure, but doing it internally. So instead of pushing down this way from above, you're reaching underneath of here and trying to rotate that baby around. Okay? So, the two of you now are actually working in concert if you're doing this well. Whoever's pushing from above should be trying to push that towards the head, the way the face is going. And inside, you should try to rotate that anterior shoulder that way, or the posterior shoulder that way. And the whole idea is to go from here to this angle. Okay? So, there's a Woods corkscrew, which is, I believe, I don't remember these. Woods is the posterior shoulder, and there's another guy named who'd like to name the posterior shoulder. Forget it, just call it the corkscrew maneuver. Forget these guys.
That makes sense.
Corkscrew. Okay, so guess what though? Doesn't work. I gotta move these down, sorry, we'll get back to them. So baby didn't come out, you tried both. What do you wanna do next?
Call you.
I'm sorry?
Call you.
Call me, okay. The truth is, I'm over at St. Joe's seeing some psych patient in the unit, and it's gonna take me 4 or 5 minutes to get across town. So you don't want that time. You want to do this on your own because you're talented. And the truth is, a person who's doing obstetrics knows these things. They become second nature to you. You're not thinking this through. That's why if you think it through now of why you're doing what you're doing, it becomes natural. Okay, so you tried the corkscrew, it didn't work. You got her legs still up in the air, her knees are by her ears, and 2 people are holding those for you. Somebody's pushing suprapubically for you. None of that's worked, and you don't have a carpet knife, so you're not going to cut the symphysis yet. What do you want to do next? What do you want to try? How can you change the geometry here?
With the patient.
Okay, I'm going to put that down here again. That I'm going to put further down here. Let's put that at 7. It's a good point, okay? There's a limitation of bone down here. What's the limitation up here? Here's the anterior abdominal wall. There isn't one. So if you put her in knee chest, okay, or not even knee chest, all 4s, okay, the baby can go this way, and maybe you can get the posterior shoulder to come out. Okay, and once you get that shoulder out, then you can get the other shoulder out. Because once one shoulder comes out, you've got the room to manipulate the baby down. So yes, going to all 4s might work. But there's something I'm looking for before that, after the corkscrew. I'll give you a hint, okay? You get to be my victim this time because you're here, okay? If you were to, you're wearing a jacket so it's hard, okay, but that's okay. So, the measurement from here to here is, guess on her eyes, what, 16 centimeters maybe? Or 16 inches? 1 centimeter, right? Does that sound reasonable?
Sure.
I don't know, I'm guessing, maybe 20 centimeters, I don't know, 20 inches, it goes. But what's the difference from here to inside the armpit? I'm losing this much. So I'm losing about 3 inches, okay? And a baby, maybe you lose about 2.5 inches. So if you can deliver one of the arms across the baby,
Okay.
reach up and get that arm to come out, the baby is going to drop that much more to allow access for that anterior shoulder to come through. So the next step is to deliver an arm. And sometimes you can, sometimes you can't. Okay? Then we're going to go into this, on all 4s. Well, that would make that 6. Number 7, symphysotomy, right? And if that doesn't work, We've tried shortening the shoulders. We've tried making the cavity bigger. None of it's working. Baby's still stuck. We're now 3.5 minutes out. You've had to hold from running to the bathroom and change your pants because you're really feeling the poop squeeze out of the sphincter, okay? Because this is mom's baby, you know, and you're responsible. What do you do next after you've done all that? Anybody? What's your last resort?
C-section.
Yeah, okay, but what are you gonna do to do a C-section? Head sticking out.
Put the baby back in.
Put the baby back in. So, that's called a Zanvinelli. Now, that Zanvinelli always allows me to talk about the stages of labor. Okay? So, babies come in to the pelvis. They're laying slightly on their side usually when they come down, and they're looking to the side. Now, in order to get into the pelvis, the first thing they do is keep their shoulders where they are. Remember, my shoulder's going to stay here. I just don't have the flexibility for this. You got to rotate the head to look straight down, correct? So it's internal rotation. Then, this part of the head right here is rectangular. This part of the head is round, the occiput. So the babies do internal rotation. Then they need to flex in order to present the round part into the round pelvis. You can't get a square peg through a round hole comfortably. So the baby then flexes, comes down, it goes under the symphysis and says, oh, where am I at? So the first thing it does is extend to look and see where it's at. But where are the shoulders? The shoulders are still facing that way. So as soon as the restriction of the vagina is released, the head externally rotates to go back to where the shoulder is. So, internal rotation, flexion, extension, external rotation. And descent's occurring all along that process. How do you put it back?
Reverse.
Externally, are you internally rotate it? Flex it? Push it in. Have I ever had to do that one? No. I'm hoping I never do. But that's how it's documented in the literature. Questions? You just saved the baby. But is there anything that we didn't do that if you really had time to think about, you would have come up with? Because it's nothing more than geometry. How do I get a straight thing through a round hole when it doesn't fit? If it wasn't a baby, it'd be easy, because you'd be able to figure it out. But now you get the fact that there's somebody in there that has to be oxygenated and has to have blood flow going to the from the placenta, because the chest is compressed in the vagina, so the baby's not going to be able to breathe. Correct? So you're not going to oxygenate the baby by lungs. It has to be through the placenta. What if the cord's stuck in that vagina with the head and with the shoulder? Baby could be really turning blue on you, and they do. Okay? So, shoulder dystocia. Questions? What are the most common risk factors for shoulder dystocia?
Obesity, gestational diabetes.
Gestational diabetes is probably the biggest one. How about normal diabetes?
That could be it.
Tends not to, because their babies tend to be IUGR and small because of vascular flows. But if their sugars aren't well controlled, yes, then their babies are going to get big. Okay? What is insulin other than a glucocorticoid? Okay? What else does it do? It's a growth hormone. So that's why if you have high levels of insulin, what do you do with glucose? You burn glucose, right? Think of it this way: high glucose, high insulin, so that you can burn off the extra glucose that you had. What happens to fat, though? If you're burning glucose, you're depositing fat. So babies look like sumo wrestlers when their sugars aren't well controlled. Their bones grow bigger, their soft tissue's bigger. They look like me at birth. Okay? So, gestational diabetes. What's the other ones that tend to be that?
The post-dates, 41, like,
Post-dates prolonged labors. That's when you have to worry about it. So when you have people that have estimated big babies, by ultrasound, their labor's protracted, and their pushing stage is long, in the back of your mind, as a nurse and as the obstetrician in the room, you should be thinking, I need to be prepared in this baby gets stuck. So what kind of things could you do? Number one, you might want to say, neonatologist, keep your shot. I want you around just in case as we get ready to deliver. What else might you do? Get a stepping stool on the table. How high do you have that table when she's pushing? If you're at the end of it, you're down there, you got a table away. If you're like me, I don't like climbing in the beds with them. I think it just looks bad, and I'm climbing in all this fluid and blood, and I'm wearing this gown to protect myself, but I'm climbing in it. I don't understand midwives in this hospital for that. The tables are designed to break them apart so you don't have to climb in that stuff. So for me, if you watch me do a delivery, it's different. I raise the table up, I take the bottom off, and I put the bag that catches all that goop. But that table's up in the air. Look at all our nurses. Few of them are tall. The rest of them are about this big.
I'm pretty tall. I like it up high.
But the rest of our
back.
large of our nurses, if they're that big, they're really stretching it. So they want pressure. If they have to do suprapubic pressure, they want to be coming down. So get a stool and make sure there's a stool in the room for them to push. Okay? Those are the things you do to prepare. Questions? You're now ready for your second emergency. Okay. Mrs. Smith, or Mrs. Smith. I just feel sorry for her.
We have two Mrs.
I'll say there's two Mrs. Smiths on the floor right now, so we just did a section on one,
And I
so.
think she's also like 22 G1.
And she is
G1
22
now.
on a G1P0, so.
Okay, this is Mrs. Smith. She this time is a Gravida 3, Para 2. She doesn't have, let's let her have gestation diabetes. That's okay. And let's let her be, for this one, let's let her be 38 weeks. Okay. And she presents to labor and delivery. It's the middle of the night. And this is what her contraction pattern. What her contraction pattern looks like. And here, we're gonna put 140 right here. Okay, and this is what it looks like. That's what her contraction pattern looks like. So, first off, tell me something. I don't have all the measurements, but just guesstimate from what you did. What category strip is that?
2?
Why?
Because
This one?
yeah,
What's that?
would that be a variable?
Variable. It looks like a variable. I don't have the measurements on there, so you're just kind of picturing this in your head right now. If I had measurements on there, you could be more, because what does that have to be a variable? We did all this stuff last week, so that's why I'm making them come up with this stuff.
It would have to have the. It would have to be 15 and 15, right?
15 beats. It has to maximum, or it has to go at least 15 beats down, and that whole thing has to last for 15 seconds minimum.
Mm-hmm.
If it's less than that, it's not a variable, right? It's just a decel. It's not important. Okay, so if I got rid of that, you'd call it a category 1, right? So I left it as a category 2, just because it has a variable on there. Okay, so that's what it looks like. So, resident gets up out of bed, because this is an open unit where we have residents and students and all the kind of good stuff, okay? And they call nurse calls the resident in at 3 o'clock in the morning and says, look, she's having a good contraction. Oh, wait a minute, we better fix this. She's 39 weeks in 1 day, so we don't want to do anything if she's 38 weeks. So, sorry, that was my mistake. So, 39 weeks, we got a category, technically a category 1, but just one little element that makes you think a category 2. But there's nothing in that that's got you worried, does it? Looking at that strip? Good. So the resident says, okay, I want to go to sleep, and this lady wants to deliver, so I'm going to break her water, and then I'm going to go to sleep. And she's going to start, because if you break water, contractions pick up, they progress along quicker. We also know if they have meconium stained fluid, if there's anything like that. So we're going to do the old action, and it's called the active management of labor. We're going to get this lady moving. So you break her water. Clear fluid comes out, okay? And Everybody's doing great, so he goes to sleep. About an hour and a half later, he gets a call. Because this is what you saw. That's what he sees. The nurse yells, "Get your tush back in here, buddy." Or lady. Is buddy a girl or guy? I don't know if it's a girl's name or a boy's name. Okay. So tells him to get your you know what back in here. So, what do you think's going on?
I feel like there may be a cord prolapse.
Absolutely.
Maybe is-
First thing you saw was variables, and then you had a drop, and it stayed down. So, let's go over here. Number one, what is the first thing you're going to do in this circumstance? Not yet.
Not yet.
Okay, what's the first thing you're going to do under these circumstances?
Exam, do a quick-
An examiner. Because you had the suspicion that maybe this was a cord prolapse. But in that history, is there anything that helped you with that cord prolapse? Suspicion. What is the most common reason for cord prolapse? Any ideas? Rupturing membranes when the head is not engaged in the pelvis. -2, diabetes suggests there might be some polyhydramnios. The head was not well engaged in the pelvis, and the resident wanted to go to sleep. So he broke the water, and if this is a river, okay, and the river's flowing that way, and I take my cup and I throw it into the river, where's it going?
Flow it up.
Going with the flow. What's the only thing small enough and loose enough inside that uterine cavity to go with the flow of water? Cord. Nothing else is there. Baby can't go. A baby goes a little bit, but it isn't going to fall out with a little tiny baby. But hopefully the baby's bigger than that. Okay, so the first thing you do is exam, and you say, "Oh my God, there's a cord laying here." So we make a diagnosis of a cord prolapse. So now, what's the second thing you're going to do now?
I would do two things simultaneously.
Oh, you're doing great. Go backwards. Take a step backwards.
I would say activate.
Thank you. Okay, because now you have a diagnosis. You know what you're dealing with. So the first thing you're going to do is call for help. Okay. Number 3. Now, let's look for a second. Let's think about what's going on. And I want you to, again, forget this is a baby. This is all about geometry. Here's the head. Here's the pelvis. The baby's fitting through. Here comes the cord. Like this. Goes back up. Okay? What is the issue right now? Is it the cord prolapse a problem?
Baby's compressing the cord.
So it's the head compression against that cord that's causing your issue, correct? Now, can you get that cord back in? No, it's hanging out too far. Now, if it's just a little cord right here, you might be able to push it up, and I've done that before. But when you got actual cord hanging out, you can't. So, what's got to happen long term here? Let's go to the end here.
C-section.
Okay, so we're going C-section. Good. Okay, so but we got to get there, correct? Now, let's paint the picture for you. Okay? You are the student that happened to be on, and the resident's in the corner crying because he's going to get chewed out because he broke this water and it's his fault. Okay? So he's telling you that you need to be the person in the room. The nurse is there. Your obstetrician that does the surgery lives in Podunk, out in the country, 35 minutes away from the hospital. Okay, so you just call him. When you called help, he's got to go pee because he's my age first, and then he's got to get in the car, so it's not going to take him 35, it's going to take him 45 to get here, okay? Because his prostate's getting old, okay? So, the anesthesia, they live 45 minutes away because it's a hospital, doesn't have 24-hour anesthesia. So you've got to buy 45 minutes of time now for this baby, okay, where that cord is not going to get compressed and cut off the baby's oxygen and blood flow, and that baby die. So, understanding what the issue is now, what's the next thing you want to do? I'm listening.
Push the head back. Up.
So you're going to push the head back up out of the pelvis. You're going to reach through the vagina, and you're going to hold the head up. So you're going to hold head up. Okay.
Triangular position.
Good.
Sorry.
Why
No,
not?
no, you're doing great, Miss.
Why not let gravity help you? It's easier to push down than it is to push up. So put the patient in Trendelenburg. Now, let me ask you a question. Do you need a monitor?
Yeah.
Okay. So if you have one there, you can track the baby's heart rate, right? What if you don't have a monitor in the room?
My finger.
And what's that going to do?
You're monitoring with your hand the pulse.
How you doing it?
You can feel the cord.
Exactly. You put the cord between your fingers so that you can feel the pulsation. So you got to wait 45 minutes in there. You're holding that baby up for 45 minutes. If you've ever tried it and been there, it's not easy. If your 45 minutes seems like a lifetime when you got your hand all the way up somebody's ooh-ah, okay, and you're holding this big bed. Because what's happening to this head right now? The uterus is doing what?
It's still contracting.
It's still contracting. Okay, so Trendelenburg, okay, and you're going to track the pulse, the cord. What can you do next? How else can you help yourself? I'm sorry?
No, I was gonna say, could you potentially give uterine at this point?
Tocolytic.
Yeah, uterine relaxation.
Absolutely. Give some terbutaline. Let the uterus stop pushing against you. What else can you do?
Give mom oxygen.
Okay, so we're going to do oxygen. How's that going to help? Remember we talked about it last week? Only going to help if mom isn't oxygenated to begin with, right?
Well, if your O2 side is,
We do it for us. We put the oxygen on there so we feel better. Because most healthy women don't need it. Their baby's only going to get what their oxygenation is. But you're right, we do it, okay? So what's next? Hey, what can you do? Think of the whole process. So you're in there, you're holding that head up, you got her on her head, you've slowed her uterus down.
so all this while we're also monitoring the fetal.
Okay, but we have two ways of doing that now, because if you're in a hospital that has lots of equipment, they have a monitor on, but you're also doing it by the umbilical cord. You're just tracking if it's a fast heart rate or a slow heart rate. Okay? So what can you do to help? You still gotta buy time. Is there anything else you can do to buy time?
Should you do annual infusion?
Not gonna help you, because remember, it's not up in the uterus where this issue is, it's in the vagina. Okay, right at the outlet of the vagina. So it's a good idea if the cord is inside being compressed, but not if it's prolapsed. So what else can you do? Let me ask you, let's take it a step further. I get asked the same question. I realize how much you guys don't watch, not you guys, but the student group don't watch what happens. What does Kim do, okay, and she's been doing a lot of this the last week or so. What does she do when the patient goes into the OR for a C-section? What are the things she does?
Anesthesia, prepping the patient.
Okay, what else does she do?
What else do you do?
You can ask her and call for help because she's here, she does it. What else do you have to do for that patient?
Calm down.
Fetal heart rate. Like when we actually get in the OR? Or
When you're in the
right
OR.
In there? We get her in there. We prep her. We put the cutter in. We get the Foley in. We do the fetal heart check.
You just said it for me. What did you just say?
Foley?
You put the Foley in.
Foley in.
What is a Foley's job to do?
Drain the bladder.
Okay, but what about if you use it to fill the bladder?
Oh, to help push
What
the
about if
baby
you
up.
push the head up,
Bladder's
fill the
empty.
bladder with
We
800
don't
cc's of
send
urine, and create a balloon to keep it out of the pelvis while you're waiting? So you fill it, clamp it, and then wait for the obstetrician, but you're still watching the heart rate, okay? So you can fill a Foley. Okay, so Foley. Okay. So, the last thing you do is C-section. Okay? When do you let go of that baby?
When the baby's taken up from the.
The way I tell people to remember it is when the obstetrician shakes your hand from inside.
I was gonna say, when the doctor tells you to, that's
When he
you
says
let
to
go.
you, or she says to you, thank you very much for saving that baby's life from the inside. Now you pull your hand out, okay? Because you are the reason that baby's still alive, because you're holding it out there, okay? So if you begin to look at this, it's nothing more than logical geometry and how do you make, the bottom line is to keep the head away from the cord. How can you do it? Okay. That was weird. Everything we do is to keep that head away from the cord. Questions?
What is the Trendelenburg?
It's head down,
Oh,
butt up
Like
and
you
down.
tilt the head so the feet are.
St. Cloud,
Gotcha.
Florida. It's gotta be Saturday something, right?
yeah.
Okay.
That's
You did that the
telemarketing.
other day too with the Virgin, with the Trendelenburg to try to move the baby.
All it does is you put the feet up in the air in essence and head down, so that instead of pushing up when you're holding the head up, you're actually pushing down. Okay? Yes,
I have a
ma'am.
question about the Foley, so, if you distend the bladder too early before the Trendelenburg position, do you have a risk of basically locking the baby in that, like,
You only want to distend the bladder when you're holding the baby up.
Okay.
It doesn't have to be Trendelenburg, but you have to
Okay.
hold the baby up
Okay.
out of that pelvis.
okay.
Because you could, but the bladder's very movable. So what you're trying to do is close the space once you have the baby up. So the baby just stays up there.
Okay.
You can't forget it. You can't walk away from it. You just takes the tension off of you holding it.
Okay.
Because it's not comfortable for mom and it's not easy for you. I've been there. You literally ride down the hallway under the drape with your hand up her vagina. You get draped in the OR with them right over top of it. You just say, thank you very much. Try not to hit me with a retractor. Okay, but when they throw stuff down and they don't realize it's your head down there. So you have to remind people that you're down there, okay? But really, I've been there. I've gone to rooms like that before. It's riding on the gurney. Okay, good. Now you've done your second savings. Okay. Now we're gonna do, I call this my graph. This is, let me draw it first. I have to do this. And then we're gonna do this. And then there's 1, 2, 3, 4, 5, 6. Okay. Here's what I need you guys to do for me. Term baby coming into labor and delivery close to its due date. Okay, let's just say 34 weeks on. Okay? What are the 6 most common reasons that people present for bleeding at the end of pregnancy?
Well, I guess the worst one would be an abruption.
Okay, so let's put that right here. Abruption. Now, what's an abruption?
Something turning away from the uterine wall.
Well, when you look at a uterus, okay, baby's in here, placenta's sitting here, and it's connected, and there is a membrane right behind that called meter box layer, which allows a barrier so that the blood vessels can communicate without crossing, but it also prevents the placenta from invading into the wall deeply, so it won't detach and get a thing called a what?
Is it a creta?
A creta. Okay, and that's where that meter box layer is weak, and the trophoblasts invade in and grab onto the muscle and won't let go. So if this area here separates from the wall and you get blood back here, okay, that is a bleed behind there, and the pressure in there increases as the bleeding increases, okay? Now, you can actually have behind a placenta, you can have 2 or 3 liters of blood, never know it's there, because it never bleeds. But some of it might work its way out this way and cause some bleeding. But if it opens up at this end here and bleeds out this way, you're gonna see it. But if it doesn't, if it's in the middle, you don't see it. But it's exactly what it is. It's a separation of the placenta from the wall, causing a bleed. You're decreasing the surface area for blood transfusion, or for oxygen and nutrient transmission. So it's going to stress the baby and create an issue. So abruption, and we'll talk more about that in a second. Okay, that's one. But it's the third most common.
Placenta previa?
Okay, a placenta previa, and we're going to talk about that more in a second. So you found the ones in the middle. Take guesses.
Rupture of membranes, premature.
Okay, let me change that for you, and let's just say labor.
What about a uterine rupture?
Uterine rupture. So there's 2 I'm missing.
Some sort of trauma or laceration to the cervix.
Not usually a term. Women are pretty careful, but it is in there, but it's further down the list in terms of. But I guess in essence, 2 can be somehow related to that, but I won't tell you how.
Could it be something like not exactly related to the pregnancy, like fibroids?
Nope.
Or, okay.
Any other guesses? How about another form of previa?
Vasoprevia?
Vasoprevia, that's the last one down here. Vasoprevia is where the blood vessels leave the umbilical cord prior to entering the placenta, and they traverse in front of the cervix, so that there's 3 vessels going through the membranes right in front of the os. Normally you would have the umbilical cord going straight to the placenta and attaching. This ends early, and what happens is somebody ruptures the membranes and they rupture baby's blood vessels. Not mom, but baby's. So that's a critical emergency to baby. In fact, you have to do something immediately or baby's going to die. What would 2 be? See, it's interesting that this is the only one that so far, I've been doing this for 3 years, okay? And only 1 group of students got it. We have a resident, we have a nurse, and they have a life where you guys don't, okay? So they may come up with this answer before you do.
Oh, okay.
I'm sorry, I'm still so new over there, I probably won't get it either.
But it's actually the most common thing we see other than labor.
Is it intercourse?
Intercourse, sex. You guys don't have sex, you're students. You're too busy studying. Hell. The most common, we see it all first. What does the nurse ask the first thing when they come in with bleeding? When did you have sex last? Because they play with pointy penises in pregnancy. The cervix is very
I do
glandular.
ask that question every time too, I don't know why I didn't think of
The cervix is incredibly vascular. And all you have to do is bump it and it bleeds. Okay, then you put a pointy penis in there. So I tell all pregnant women, sand the tip of that penis down before you play with it. Okay, so now, this is the reasons for bleeding. What I want to know is next, is there pain involved? So, do you have pain with labor?
Yes.
Yes.
Okay. After sex is done, do you normally have pain?
Depends.
You should not.
How pointy it is? No, I'm sorry. Okay.
You shouldn't.
Okay. Does Abruption cause pain. Why?
Yes.
Why?
Separated from the uterus.
What's that got to do with it?
The uterus has pain fibers that the mother can sense, whereas for example for vasa previa, that's the babies.
Take it out of the fact that, forget for a second that it's a placenta, okay, and a baby and a uterus, okay? If you bleed into your leg muscle, does it hurt?
Yes.
Okay, why? Because the fibers are being irritated. If you bleed into your leg muscles, okay, because you get a contusion, what happens to your leg muscles? They start to squeeze to stop bleeding because they think that's what they need to do. So they go into spasm or tetany, okay? And that's most of the reason, because it hurts. The muscles are responding to that. If you have a placenta sitting here, and it's sitting right here, and the bleed is here, and it's continuing to bleed and continuing to expand, I gotta draw this way for you so we show the outside membrane. It's also expanding into here, okay? And one of the signs of an abruption is when this ecchymosis makes it out to the surface. And if you do a C-section for an abruption, and you look at the uterus, you see that ecchymosis on the outside of the uterus where an abruption occurred. It's called a Cuvier's uterus. And it's a sign of an abruption. But all it really is the blood making its way to the surface in the serosal membrane. But this is going into major spasm to try to stop the bleeding. So what happens to the contraction pattern? Boom, 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 boom. One after another, they start contracting.
Before you leave, can you stop? Because I have to chat with you about something.
Okay.
Okay.
It's okay. So you see a hypersystole type pattern, with contraction after contraction after contraction. One of the benefits to that is if baby's close to delivering, it may deliver quicker. So sometimes an abruption, because of that increased contraction, may deliver very quickly. But it also causes severe pain because those muscles are in spasm. Okay, so positive. Placenta previa, does it cause pain? Why not?
Because it's bleeding, it's not involving the muscle, it's more on the other side.
Okay, so let me draw this differently. This is the same uterus. This placenta is here with the cord coming off. Okay? When it bleeds out of the vagina. Okay? It's not bleeding in the uterus. It's bleeding into the vagina. Okay? So, there's no pain associated with it. How about uterine rupture? Rupture anything hurts. Positive. How about vasoprevia? Any pain? No. Number one, it has nothing to do with mom. It's all baby. Maybe baby's in pain because it's exsanguinating, but you wouldn't know that. Okay. Quantify for me blood loss. What I mean by that, can you look and see approximately how much blood she's losing? So, how about with labor?
Not too much, then,
Why not?
maybe 250.
That's not what I'm asking.
Oh.
I'm saying, can you look at what's going on and decide in your head how much blood loss there is?
Like small, moderate, large.
Yeah.
Like if I called you up and said, hey, I got a patient here, she's got massive amount of bleeding versus small little spotty.
So you can pretty much look at her and say she's losing a little, she's losing normal, she's losing a lot. Think of it that way. So absolutely you can quantify this. Sex is self-limited, so it really doesn't fit even in our paradigm here. We sent home, right? Because she finished having sex and she went home. Abruption, can you quantify visually the amount of blood loss?
Not always.
Not always. You really can't because it might all be sitting behind the placenta. What's going to be your clues of blood loss? Vital signs, baby's response, mom's hypotensive and tachycardia. I'll bet you she has a bunch of blood sitting inside that uterus behind the placenta, so that you cannot quantify that blood loss. Okay? How about placenta previa? Can you quantify the blood loss? Absolutely. You look at it. It may be a crap load of it, but you can say that. There's a ton of it. How about uterine rupture? No, it's in the abdomen. You have no idea. How about vas previa?
Yeah.
Absolutely. The only difference with vas previa, a little's a lot more, because baby doesn't have much blood to begin with compared to mom.
Now, how would you know if it was baby's blood or mom's blood? Like, if the woman comes in, she's bleeding, how would you know? What's
Well,
the difference?
because you would immediately see baby go into fetal distress because it's literally bleeding out.
Okay.
So you may not know it 100%, but you
Like, the
know
minute mom
baby's
comes
in
in, I
deep
would
trouble.
know, but I put baby on, or mom on fetal monitor and baby.
You're gonna have a heart rate in the
rapid
60s.
racing, I would know.
Yeah, you're gonna rush and get that baby out anyway and find out that it was a vas previa.
Okay.
Sorry. So, this is an interesting question that I always put up here because I think it's important to think in your mind, okay? But risk for DIC without knowing it. So, a patient will go into DIC and you had no idea she was even going there. Now, how about labor? Why not?
Well, if you knew the blood type of the mom and the baby,
Does DIC have anything to do with blood type?
if there's any mixing and
Well, what's DIC?
disseminated intravascular coagulation.
And what is it caused by? It's fun to do this. I'm not putting you on the spot. I want you to think through it. What is DIC?
Platelets clotting up, like consumption of platelets.
Consumptive coagulopathy is another name for DIC, okay? What's happening is there's so much bleeding going on and the body is trying so hard to stop the bleeding and it runs out of things to stop it with, okay? In fact, years ago, somebody said, wait a minute. It was an interesting concept. They said, if that's really the diagnosis, why not give people heparin first? Stop their coagulation so they can build up factors. And somebody else looked at them and said, yeah, so watch the patient die while you're giving them heparin. But that was the thought process, because if you think it through, that makes sense. If it's an overusing of the system, shut the system down, you're gonna have more system, but the baby's gonna bleed out. So it's due to so much bleeding and patient runs out of coagulation factors and now starts bleeding because it can't stop itself. Okay? So, in labor, what are the chances of you not knowing that patient was slipping into DIC? You know how much bleeding's going on, right? You're gonna know. So it's not significant. Oh, let's get rid of this guy already. Okay. How about
Very
abruption?
high.
I'm sorry?
It's very high for sex.
There you go, very high. Right. How about abruption? Why?
Because you can't see it.
Because you don't know how much blood loss is going on. So you can see these are helping you know what's going on. How about previa?
Possible.
Are you going to know it?
Yeah.
Yeah. So it's not going to happen when you don't know it. How about uterine rupture? Is it going to happen when you don't know it? Absolutely. And what about vasoprevia? Not to mom, but baby may.
Baby, but not.
Okay, but not mom, so you put a negative there. Alrighty, so now that you're looking at these things, a patient comes in with bleeding, you can begin to look at pluses and minuses and make a diagnosis of what's going on for those people, just based on what you know so far. So, the patient comes in with bleeding. What's the first thing you're going to do? Number one.
Maybe get a history of
History.
what's been going on.
Okay. So history's going to help you a lot, right? I just had sex with the whole football team. And I'm bleeding now. Okay. Or, what else might she say? My doctor's been watching me because my placenta is very low down around the cervix. Okay? She has a placenta previa. She knows it, or she thinks that's what he's telling her. So that might come into the history. Okay, so first thing you do is that. Okay, what do you do second?
Physical exam.
Okay, physical exam. What do you do in the physical exam?
Look.
I mean, what is part of your physical exam when this patient coming into labor? It's not the physical exam you're doing in the office. You're not going to check her pedal pulses, and you're not going to check if her if she's intact mentally, because she's probably all crazy with hormones right now, and she's not thinking right to begin with. So, what physical exam are you thinking to do when this patient comes in the door?
Ultrasound.
Okay, ultrasound. But I was going to put that down here for you.
Just like a vaginal exam.
Do you do a vaginal exam?
Sterile.
Do you do a speculum exam?
Sterile.
No.
Why not?
Because if there is previa,
You could disrupt the placenta. So, you don't do, I was trying to get you to say that, thank you. But I was trying to get you to say it the opposite way, which you were going to say, I'm going to do a pelvic exam. And I was going to say, no, this is why. You do not put anything in that vagina. I mean, check her cervix, anything, until you verify where the placenta is. Because the worst thing you could do is put your finger up there and stick it right through the placenta. Because that's what's presenting. Okay? So in your physical exam, I mean you're going to do vital signs. You're going to feel mom's abdomen. You're going to check baby's heart rate. You're going to make sure mom's breathing okay. And you're going to do her general stuff, but you are not going to do a vaginal exam. Now, once you do an ultrasound and you find out where the placenta is and what it looks like, now you can check her if you want, if it's not a previa. And maybe she's already 9 centimeters because she does have an abruption and it's her 4th baby. Baby's okay. She's abrupting, but she's going to deliver before you have every chance to section her because baby looks okay. So here's my next question. History, physical exam, ultrasound, and now treatment. Okay. Labor, what do you do?
Deliver.
Deliver. Do you need anything special for a normal laboring patient in terms of any special orders for this
Pain.
lady?
Pain
Huh?
management, maybe.
That's not special. Pain management, observation, Pitocin possibly if you need it, fluids, that kind of thing, but nothing special. Sex, I'll send her home.
Lubrication.
Lubrication, there you go. And with a file for the penis tip, right? Okay, now let's talk about abruption. What's the treatment?
If they're delivering, deliver quicker.
Okay, based on what? What is going to make you deliver quicker?
Mom's vitals, baby's signs.
So it comes down to is mom or baby on this side of that justice thing that we talked about, okay? And vaginal delivery over here. If mom's stable and she can deliver vaginally, there's no reason not to. If baby's stable and she can deliver vaginally, there's no reason not to. But if mom or baby are in trouble, you throw the towel in and you deliver her by C-section. But what else do you need? What else are you going to order for her?
Blood typing.
So you're going to type and cross her. Okay. Type and cross. That's not a cross, that's an X. Type and cross. What else you going to do? Look at your graph.
Pain management.
Okay, so she might need pain management. Thank God you guys are compassionate.
CBC,
Okay, you're gonna do routine lab work, okay, but what else are you gonna add different? A CBC?
is it the vibrant, no. What's that thing
An
called?
FDP? Fibrin degradation products? Or fibrin split products? What does that tell you?
If there's any, if it's occurring, the coagulation.
If it's elevated, it comes back reading 3 different ways. Less than 5, 5 to 25, or greater than 25. If it's less than 5, there's no immediate DIC risk. 5 to 25, you better keep an eye on her. If it's greater than 25, she's already in DIC.
What test is it?
It's a fibrin degradation product or fibrin split products. It's the same test. It's just 2 different ways of naming the same thing. So, what else you want to do? That's because you just did medicine, didn't you? Because most people don't come up with that right off the bat. I'm proud of them. What else? Read across your category. What else are you worried about?
Does that include like need for FFP?
Thank you. You need platelets available. FFP. Okay. And you think it would be helpful to have NICU?
Yes.
Okay. But you see how you begin to be prepared based on what's going on for what you're going to need in that patient to make sure everybody's good. And your nurse, who's doing a great job, is watching that patient like a hawk. She's watching her blood pressure, she's watching her vitals, she's watching the strip. She's not leaving that room because she's scared that that mom is going to go over that edge and she's not going to see it. So she's doing frequent vital signs, especially if we're going to try to let her labor vaginally. Okay, so platelets. Do you ever ask? A platelet pack in this hospital is 5 units. Okay. In a hospital I came from was 6 units, but I think here it's 5 units. How many packs of platelets do they keep in this hospital at a time? 2. So, trauma comes into the ER, and you're even concerned about this patient. That's why you have to call ahead of time. Because they may have to go to Guthrie, they may have to go to Rochester, they're going to have to go somewhere to get more platelets. They cannot, they're too expensive and they don't last as long. So they can't keep them in-house. These are the kind of things in preparation that you need to think about. 2 packs.
That's horrible.
Well, it's a cost thing. I guess that's what they think they use. Okay, how about placenta preview? What do you want to do for this one?
What week is it?
I'm sorry?
What week is it?
Let's just make it easy for you, okay? She's greater than 34 weeks.
Planned C-section?
Okay, when?
37 weeks.
But she's bleeding.
Oh, then immediate.
There you go. If mom is bleeding from a previa, you gotta section her. There's no other choice. Now, previas classically come in with what's called a heralding bleed. They come in with an episode of bleeding. You think they're dying, and it stops. So you bring them in. Now, if they're greater than 34 weeks, deliver them. Those babies are gonna do fine. If they're under 34 weeks, then you wanna buy steroid time. Now, if they're in that 34 to 35 week and it's just bleeding that stops on its own, there's still some argument now that giving them that dose up until they hit that 36 week is worthwhile for steroids to help baby because it's gonna need it. But you can't predict when she's gonna bleed again. If she's under 34 weeks, now you wanna see if you can buy some time and steroids. But what do you wanna order for her when she comes in? Type and cross, because unless you're standing there and watching her hemorrhage, and now you've got to go after DIC things, but you'll know that by the amount of bleeding she's doing. See the difference? One is reactive to how much bleeding, the other one is reactive to the condition we're dealing with. That make sense?
One more time.
Okay. With abruption, okay, you're not seeing bleeding, but you know the potential's there for you to have it without knowing it. So you're going to order those products ahead of time. With a previa, you're either having enough bleeding that you need them, or you're not having enough bleeding and you don't need them. So you can judge whether you need them or not. Okay, so they're not something you just order, because her bleeding may not be that bad. Remember, mom has double the volume in her system. They double their volume. Uterine rupture. What do you need for uterine rupture?
Similar stuff to eruption.
Correct.
Same as 3.
What's the first sign that you see clinically that the uterus is ruptured? Any ideas? Take a guess. Jump into it.
Would just be like a rock hard uterus.
Okay, if it ruptures, you think it would be rock hard?
I imagine it'd be like clamping down, contracting.
Okay, but there's probably a big gap in the middle of it and something's coming through it, right?
Okay.
Which is maybe if she's not ruptured, if she's not, her amniotic fluid's not ruptured, what's that's gonna be bulging through? Fluid. And what's fluid feel like? It's soft and spongy. So hard isn't gonna be the thing you're gonna affect. In fact, when you have a intrauterine catheter inside the uterus, when a uterus ruptures, one of the signs is drop in uterine tone, because the wall has been disrupted and it doesn't have the ability to constrict. So, but what's the first sign that is classically thought of for people who have uterine rupture?
On the fetal heart tracing.
Correct. Fetal heart tracing abnormalities. They start having decels of some type, or whether they be variables, whether they be lates, whether they be fetal tachycardia. There's something, and there can be a lot of reasons for it. It could be that the placenta is where that rupture is occurring and it's causing some separation. It could be the cords pushing through it. It could be the baby's protruding through it. But on any test, the first sign of uterine rupture is a fetal heart tracing abnormality. What's the second sign? You already gave it to me. Uterine tone, if you have an intrauterine impression catheter. What's the third sign?
Vitals. Mom's vitals.
Interestingly enough, okay, most uterine rupture occurs when? What circumstance? Previous cesarean section or previous uterine incision. For example, if they have a myomectomy and they disrupt the uterine wall, those are people that are also at risk for uterine rupture. So there's some incision that's been made in there ahead of time. Incisions heal by scar. Scars tend to be avascular. So most uterine ruptures rupture in an avascular plane. It's only if they extend laterally, okay, where they're going to extend into the uterine arteries on both sides. But actually, if you go in under C-sections and you see moms that have a window in their uterus, they don't bleed from that. It's so thin and it's a scar. So that they tend not to bleed, but if they go laterally and tear into the uterine arteries. So as a late sign, that would be vital signs on mom. But what would be a sign to tell you that the uterus has ruptured, that you can bring back to your physician, or as obstetricians, you can make the decision that that's one of the clinical things that's going on? What about the head that's going up instead of down? So you got a head that's in labor, it's at +1 station, you go back to check her again, now it's at -3. Why is it -3? Uterus opened. The head came right out the front. Or there's nothing pushing it down anymore. It expands. So a rising head in a previous cesarean section is a very worrisome sign that there may be a uterine rupture going on. What's treatment of choice?
Deliver.
C-section. Correct. Okay. Vasoprevia. What is going on with the vasoprevia?
Baby's bleeding.
Baby's bleeding to death. What do you need to do?
Get it out.
Call NICU
Yeah.
and do an emergency C-section as quickly as you can. I think that's enough for tonight, don't you think? Did this help you?
Yes.
Are you more comfortable? If you notice now, go back and fill the gaps with your books. But the truth is you don't need them. You know the stuff now. You understand how to think through it. So it's not something that you have to memorize anymore. You have to just think through the process. Okay? Yes, sir.
Cool. So when you have back to the uterine rupture,
Mhm.
after the C-section, is it likely that you'll just do a total hysterectomy?
Sometimes you can actually carve out the area that's ruptured, and if they want to have more babies.
Mhm.
If they don't want to have more babies, you can do a hysterectomy, but usually you can sew that uterine rupture up, okay? So that, but there is a high risk if they rupture once. I doubt I would let them VBAC again. Now, with uterine incisions, the only type you let VBAC are people that have a low transverse incision, low down in the cervical area. And why? There's more collagen down there, and the pressure lines are less likely to rupture. The old way, when they did classical vertical incisions, it's all muscle. Muscle doesn't hold together very well. So that when the difference is low transverse uterine incisions, if they're going to rupture in labor. Vertical or classical incisions, large myomectomies or removals of fibroids, they tend to rupture before labor. So people who have a classical cesarean section previously, or a large defect made by a fibroid, will be scheduled at 36 weeks for a cesarean section, so that they never go into labor and never extend it out any further. So that's one of the exceptions of when to do a C-section early. Okay? Go enjoy life. Yes, sir.
If you've already had like the longitudinal C-section, when you do a repeat C-section, do you now go for the transverse?
I do.
Okay.
You can do it vertically, but sometimes it's hard to find that incision. You can't see it, and it's less likely to tear apart if you do it transversely, so why not? You're not going to let her VBAC anyway. Her third C-section is going to be low transverse, and her fourth C-section is going to be low transverse. But you're still going to deliver at 36 weeks because you're still afraid of that classical incision. Now, also, you got to be very careful. If you weren't the one that did the delivery and you're not in the institution, let's say the patient came from West Fargo, up there somewhere, okay? And you see a transverse skin incision. Do you know which way the uterus was cut? No. So you need to get those records before you let her VBAC. Because even though she has a transverse incision, she still may have a vertical uterine incision. So here, everybody does for transverse. So it would be rare for someone to have a vertical incision here unless it was a dire emergency. And I guarantee you the patient was told never to do it, never have a VBAC again. So it's when you're outside of your area, make sure you verify what type of incision was made. I think it's enough for tonight. Go enjoy your holiday. Have a good night. Okay,
So
see
enjoy your holiday as well.
I will. Next week, we're going to do, what is next week? It's, okay.
New Year's
On Tuesday night, unless they let you go early, but I doubt it the way you guys are going, we're going to learn all about preeclampsia on Tuesday night. It's a great disease to understand. It's so common, and I think you'll enjoy yourself once you learn this way. Okay?
Okay.
Good.
Thank you.